We're going to discuss the mTOR pathway. I'm going to show you a little bit about mTOR inhibitors and how they work in terms of the molecular pathway. It's just, sorry, I think my internet might have cut out. I'm going to try to get a more stable connection. Can everyone still hear me?
Mm-hmm.
Okay. We're trying to talk about indications for mTOR inhibitors and some side effects, and then talk a little bit about what's new and exciting and coming up. Here Maria and I can share a little bit about, I don't really have a lot of it on the slides, but if you're interested, we can share a little bit about some exciting research collaborations and ideas that we have for innovations related to mTOR inhibitor therapy, which we're very excited about. So we all know this TSC is in about 1 in 6,000 people, and it's an autosomal dominant genetic condition, which we know. So if you have it, you have a 50% chance of passing it on to your children. It's mutations in the TSC1 and 2 genes, and this leads to the development of benign tumors in multiple organ systems. And what we really are, is interesting and hard about TSC is that it's so variable, right? Like there's so many patients with TSC that are just so different from each other. And right now we don't really have a good way to help predict what's going to happen to everyone. And so this is something that Maria and I face a lot in clinic, and I'm sure many of you have experienced in terms of like coming to your healthcare provider and asking them like, what's going to happen? Like if it's your child or it's you. We don't really have good predictors yet, apart from TSC2 that can be more severe and TSC1 can be less severe. But even there is variations within that. As you know, there's many age-related manifestations, and so we can give you some idea about what may happen, right? As we know that the cardiac raptors go away. We know that the neurological manifestations are very prominent in childhood. So we have some patterns and some things that we can share, but for the individual patient, it's very hard to predict. And so that's an area of our research that we're very interested in. And I'm a pediatric neurologist, and so I see a lot of the epilepsy and TAND and neurodevelopmental challenges that come in childhood. And this picture you probably would have seen many different versions of, but I think it's a nice summary of all the different manifestations that we see. So in the central nervous system, as you know, epilepsy is very, very common. TAN, so the TSC-associated neuropsychiatric disorders are very common. Subependymal nodules are more common, and then SAGAs are less common. And then we had talked about the LAMs already, and then there can be some other lung manifestations as well, and that's more in adult women, the LAMs. And then we also touched on cardiac rhabdomyomas, which can be detected antenatally and usually in babies, and less so as tend to regress as kids and adults grow up. And then we talked about AMLs and kidney function. There can be other things that happen in the kidney as well that are less common. And then lots of things happening in the skin as well as in the teeth. And then, of course, many more things in the eyes, retinal astrocytic hamartomas, and then many more things that can happen that aren't pictured here. Here I wanted to show you, I was looking through different papers and I wanted to show you just how many clinical trials there have been of mTOR inhibitors in TSC over the last 15 years. So there's really been a lot. And this paper, I think, only goes up to 2020. Oh, here they have like a trial that goes into 2026. But you can see that there's still many trials going on and recent trials. And there's still so much we don't know. And I can tell you a little bit about the things that we do know very well that really usually mostly pertains to the SAGAs and the AMLs. Like those are things that are FDA and Health Canada approved and like things that we see very clearly in clinical practice, like those seem to respond. In epilepsy, there also is a clinical trial, and it's FDA approved indication, but not a Health Canada approved indication in terms of epilepsy. But we know that many other things, like we know cardiac rhabdomyomas, like Maria and I were just discussing with one of our cardiologists, like cardiac rhabdomyomas also seem to really respond really well to mTOR inhibitors, but it's not currently an indication in terms of being approved, but it's still used. And then we know, like, so there's kind of things that we know that it works well for. Other things like the TAND, like I'll show you, been some studies where maybe things get better, but it's really not clear. And so there's still lots of work to be done in knowing where to use mTOR inhibitors and how to use them and what and who they're going to work in. So if anyone has a science background, maybe they'll like this slide, but I wanted to show you. So as you probably already know, so TSC has to do with the mTOR pathway. So the mTOR pathway is a really interesting pathway because it's kind of a really complex, broad, like pathway that affects everything in your body. And so that's why there's so many different manifestations of TSC, like in many different parts of the body. And so normally we think of it as mediating cell growth. So being responsible for cells growing, cells dividing, metabolism of cells, cell energy, so like how cells use energy, and nutrient status, so how cells use the nutrients around them. And we know that mutations in TSC1 and 2, so like a spelling mistake in how TSC1 and 2 protein is made, can lead to the overactivation, and that means like increased action of this mTOR pathway. And that's because it's basically like a double negative. What happens is when those proteins don't work, they're not inhibiting the pathway anymore, so they're not stopping the pathway, and so that pathway kind of goes like into overdrive. And that's why you get like the formation of all these tumors everywhere. So that's basically what's happening. And so you get formation of the tumors, and these are not, as you know, these are not cancerous tumors, but they're like tumors that can sometimes still grow, but they're not cancer. Um, and then also, we definitely know there's stuff that's happening that's not forming the tumors, right? So for example, in the brain, we have formation of the sagas and the sens and the tubers, but there also must be something happening outside of that because sometimes kids with some kids with epilepsy don't actually have any tubers, but they still have epilepsy. Or like some kids have TAND and they don't have tubers and they don't have sens or sagas. And so there must be something else happening in the brain that's related to how the neurons are growing that's affected by this pathway. And that's because this pathway affects like all the cells in the body. And so that's why TSC affects so many parts of the body, so many different parts. That's why it's so challenging to get on top of everything. So how do the mTOR inhibitors work? So I mean, the good thing about knowing the underlying mechanism of action of TSC, so the good thing about knowing like what pathway is affected in TSC is that that's how you potentially can think about therapeutic targets or drugs that can affect this pathway. And so that's where the mTOR inhibitors come in. So because we know that TSC is because this pathway is on overdrive, well, if there's a drug that can kind of slow down the pathway, then maybe that would work. And that's what we're seeing with these mTOR inhibitors. So just again, thinking about how TSC is a problem where this pathway is overactivated, like going too much. These mTOR inhibitors are then slowing down the pathway or decreasing the action of the pathway. And so this means this could be a potentially useful therapy for TSC, which we've seen. So this is just like the molecular structure, what everolimus and sirolimus look like, in case anybody is a chemist. This figure, I have to give credit to we had a really lovely medical student who's still working with us, who made some really nice figures for us. So I stole this from one of her talks. Her name is Ritash. But it just basically summarizes, so we know that TSC has to do with mutations in TSC1 and 2, and these are the associated protein names. And basically sirolimus and everolimus, or the mTOR inhibitors, are acting to inhibit the mTOR pathway. And so the manifestations that I'm going to focus on are the SAGAs, the subependymal giant cell astrocytomas, and the renal angiomyolipomas, the AMLs, and drug-resistant epilepsy. So these are the things that probably the three most common, and then also cardiac rhabdos, but I'm not mentioning that as much. But these are the three things that we probably use mTOR inhibitors the most for. But we also know that mTOR inhibitors can have side effects, and that's because this is a pathway that happens in so like everywhere in the body. And you can kind of think of it as like similar to cancer treatments, right? Like cancer treatments also try to decrease cell growth, and decrease the growth of cells that multiply a lot, right? Because that's what cancer is. But then therefore it's affecting not just the cancer cells. And so like these mTOR inhibitors are not just affecting the cells that are affected in TSC, they're affecting all the cells, right? Because it's a systemic medication that you're taking, unless it's something topical like the topical rapamycin. And so you can imagine that there's side effects that happen if you're affecting the mTOR pathway in healthy cells, and that's where these other side effects come in. And we'll talk a little more about that. So I'll talk about it in SIGAs. So just kind of going through the history of it and really how recent everything is. So in 2006, there was a first case series, so meaning there was the first paper that described patients. 5 patients with TSC and SIGAs were treated with rapamycin, and they saw that the tumors were all shrinking. So that was good. And then after that, so once you kind of have like a case series, like you kind of describe a few patients, then you need to do a clinical trial with like lots of patients and like a much more rigorous study where like a lot more things are measured properly and it's all like very controlled as much as possible, because sometimes things just happen coincidentally and you want to be able to prove it in a clinical trial to once, that's how medications get approved. So after that, they did a bunch of clinical trials that really showed that this really worked. We do know that if we stop the mTOR inhibitor, then they can grow again. So that is another problem with this drug, right? You have to be on it long term. In October of 2010, the FDA approved everolimus to treat TSC-associated SIGAs. And then in 2012, Health Canada approved everolimus for SIGAs as well as AMLs. And the great thing about mTOR inhibitors and SIGAs is that, I mean, I don't know, Maria, can you think of even, unless the kids are presenting with like increased intracranial pressure and can't be on an mTOR inhibitor for some reason, like we usually like, I mean, definitely neurosurgery is always saying like they need to be on an mTOR inhibitor first, right? Before they consider neurosurgery. But you can imagine that a lot fewer kids would need neurosurgery after being on an mTOR inhibitor, which is really good.
And actually, for us now, our neurosurgeons now know, and they just kind of say, let's get them on an mTOR inhibitor, and then we'll monitor, and they won't even talk about surgery unless there were a few patients that felt their children couldn't tolerate the side effects of that, but that's very rare. So this is kind of treating first with the mTOR inhibitors now. That's sort of the standard of care that they follow.
Yeah, so that's really great. And then I wanted to talk a little bit about epilepsy since I'm an epileptologist. So again, people observed that seizure frequency would go down. And then they did do a clinical trial looking at whether it was effective and safe for patients with TSC to take sirolimus or sorry, everolimus that had refractory epilepsy, so epilepsy that was not responding to 2 or more drugs. And they did find that there was a good response rate in both low dose everolimus and high dose everolimus. It is FDA approved. In Canada, it's not Health Canada approved. I would say that so that helps us, that kind of runs into some challenges because we like to be able to try mTOR inhibitors in kids with epilepsy. I will say, and Maria, I think also thinks this, like maybe it's a combination of, I don't know if it's the best anti-seizure medication, and then I also don't know if we try it and like because the anti-seizure medications we can just kind of try whichever ones we want. Whereas mTOR inhibitors, it's a little bit harder to get. So then sometimes people are a bit more reluctant, and then also because of the side effects. So I think we kind of think of it as something that's worth trying in kids with TSC and epilepsy. Maybe not like a slam dunk, always like the best, most effective anti-seizure medication, but probably worth trying. And it probably works well for some people. And then, so cardiac rhabdos. So usually cardiac rhabdos get better on their own. As we know, they kind of spontaneously regress. That's kind of naturally what happens. But if there are multiple ones or big ones that are interfering with heart function, then they may require treatment. And Maria and I was just, like I was saying, we were just chatting with one of our fetal cardiologists who will oversee antenatal treatment with mTOR inhibitors. So if it's a pregnant woman with a fetus that has been found to have a large cardiac rhabdomyoma that seems to be significantly large, they will consider putting them on an mTOR inhibitor and can be very effective. And then renal AMLs. So as we know, they can contribute to chronic kidney disease and bleeding inside the kidneys, and these show really good response to everolimus. And in the 2012 recommendations, international recommendations, they recommended the mTOR inhibitors as a first-line treatment for renal AMLs for those that were bigger than 3 centimeters, even if there were no clinical symptoms. And so this is, very standard, very routine. Our nephrologists are very used to. And then for the skin, so initial studies showed that also they responded well to, so the facial angiofibromas, they also responded well to systemic mTOR therapy, so like taking it for the whole body. But people felt that the side effects were kind of too great if you were to take it systemically only for something that happened on your skin. And so then they did the first study of topical rapamycin in 2012 that showed that it was safe and effective. And so that was included in the international recommendations. And something that I found that was interesting that some of you could maybe speak to whether you actually see, it's noticed that younger children actually respond better. Maybe the newer facial angiofibromas have more vascularity, meaning have more like blood vessel component to it. And maybe that blood vessel component to it responds better to the mTOR inhibitor. And so they think maybe early treatment is better. Of course, mTOR inhibitors come with their side effects, right? So they seem to work really well for some things, but I think a lot of the times the side effects can be difficult. And I think what has been described and what we kind of see is that a lot of kids, a lot of patients can get side effects. They tend to be on the mild side, but it can be quite common to have side effects, even if they're mild. So stomatitis or the oral ulcers are quite common. So in the literature, it is described to be 70%. Hi, Raymond. I see your question. I'm not familiar with that HIFTOR. Could you tell me a bit about that?
It's a formulation by one of the pharmaceutical companies. I think it might be Jazz Pharma, and it's in a tube that you can get. Apparently, it's available in the United States and Europe, but in Canada, it's very hard to come by and it's very expensive. So I was just wondering, I'm hoping that it can somehow be more accepted and more popular in Canada at some point. But
Okay.
it gets rid of the idea of having to have a compounding pharmacy to make a a lotion for the skin lesions. But
Okay.
yeah, I'm hoping in the future it'll be more common.
Is it Jazz?
I think it's Jazz, but I could be wrong about that. It's
Maybe I'll look it up.
Jazz Pharmaceuticals, yeah.
Okay, good to know. Yeah, the US, I mean, gets a lot more, oh, it's Nobel Pharma. They often get a lot, well, it's just because the market is bigger, so they get a lot of formulations and things before us. But yeah, it's good to know. I don't know, maybe we'll ask our colleagues about their experience with that, our American colleagues. Thanks for the question. Okay, so oral ulcers, very common, usually mild. If they're severe, they usually tend to go away if you stop the drug or reduce the dose. You can use mouthwash. The other common thing that we run into and that's described is infection. So because it's trying to decrease cells that divide a lot, this can also affect your immune system. And so then you can see fever, diarrhea, nasopharyngitis, so inflammation of your nose and throat area, upper respiratory tract infections. Usually mild. There have been more severe infections described. And they say that if it's really mild infection, perhaps you can continue it. But the problem is if you have a more serious infection, then you'll have to stop it or pause it. Other side effects, so you can get a brush, menstrual irregularity, and then also you have to keep an eye on kind of the metabolic profile because You can get hyperlipidemia, so like a increase in your lipid markers, and then also hyperglycemia. And so those are things that we monitor with blood work, but obviously can run into issues if you have those kind of pre-existing. And then the last thing is, and what's next? So you can see that we have some things that respond really well to the mTOR inhibitors that we have right now. But some of the clinical conundrums that we run into now are which patients will actually respond well to mTOR inhibitors, and then also if there can be other manifestations that might respond better to these mTOR inhibitors or to different mTOR inhibitors. So people have looked at things like, oh, are there any markers on imaging that can predict that, for example, this renal AML will respond better to an mTOR inhibitor? So they've looked at some imaging markers on CT. Are there any blood markers? So I just put an example of like one study that looked at one blood marker called VEGF. So like, are there any markers in the blood? Like, could we do a blood test where we can see you have an elevated marker of some marker in your blood, and then that can tell us if you respond well to an mTOR inhibitor? Again, we don't do this in clinical practice right now, but that would be the hope. Are there any genetic markers that we could use? So this is something that our group is really interested in. So in your genetic code, is there actually something that tells us maybe one, like what's going to happen with your TSC, and then two, how you'll respond to medication, or maybe what medication will work really well for you? That's kind of the future. And then kind of to go along with that, we probably need new medication. So rapamycin sirolimus is quite old, everolimus is slightly newer. We probably need new medications that are more selective on the mTOR pathway or act on the pathway in a more specific way, such that we try to increase its efficacy or increase how well it works, and then decrease the side effects, because that's kind of what we're always trying to do with medication. And so Maria and I are working with somebody at SickKids, a scientist who's interested in the mTOR pathway, who is actually very interested in testing lots of different compounds, including new mTOR inhibitors. So I just put the name of one of them there, INK128. Potentially, if they can be shown to be effective in the lab and in animal studies, then maybe this can be translated to patients in human studies. So, but this process takes a long time. And that's everything we have. Oh, actually, no, that's Maria. I don't have our other
Oh,
on there.
hold on. I'm going to go into my, nobody